Hi, my name is Megan Birdwell. I'm enrolled in Anesthesia and Surgical Assisting Summer 2024. My student ID is 3631817, and throughout this video we're going to be discussing the tasks and procedures that go on throughout the day for surgery. So for any patient that's going to be presenting to us for a surgical procedure, here we do require at least an establishment exam beforehand. So whenever they are a new client to us, they do fill out this paperwork. So this is all of the client information, and then each pet that they will be bringing to us will go here. So this is all of the pet's information, such as the species, their breed, color, age, if they're male or female, spayed or neutered, their microchip number if they have one, and then the type of heartworm prevention that they are on, and then if they have any records from a previous vet or any vaccine records, anything like that. Once they are added to our AVImark system, we will go into the system, and for example, this was a new patient that saw us today. The receptionist will scan whatever records that they have, or either call the previous clinic and have them email records to us. Either way, if they scan it in or if we get it via email, it is attached to their account, to the patient's specific account. So you would just go to attachments here. So you would just go to the attachments tab here. It would be under the line item records received, and then you would click on attachments over here. And then it pops up with the attachments under that line item. In this case, it is the patient record, so you would double click on the patient record, and then all of the patient records that we have received will pop up for that patient. And that's how we do it for all of our patients. We scan in all the records, so it will be under each patient's record under their profile on AVImark. If it is a patient that has a standing relationship with us and we've been seeing the patient several times or for a while, we will still check their patient record before any procedure and before they come in to check in that morning. So we will just check their signalment, their age, if they're spayed, neutered, all of that stuff. Their AVImark profile has everything on file for them. Each tab you can go by chronological order through like the last chronologically the last exams that they've had with us. You can go to the diagnosis tab, and this is going to pop up with everything that they have been diagnosed with. So you will usually check this tab to see if they've been diagnosed with, say, any like heart disease or respiratory diseases, liver disease, kidney disease, anything like that. We want to check all of those things before their procedure. We will also check to make sure that they are up to date on their vaccines. They have to at least have their rabies vaccine before surgery, which is required by law. So we at least have to have a current rabies on file. If we do not have a current rabies on file, then we cannot do the procedure. So we'll check their vaccine records. We will also check previous lab work. So if you go to the lab work tab under the profile, it will pop up with all of the previous lab work that they've had in the past. So we can go to their most recent lab works and see what their previous lab works results were. And then you can also go to the surgery tab, and you can check to see if they've had any surgeries with us before in the past, what that surgery was, and then you can look at the surgery notes just to see how that surgery went, when that patient was under anesthesia, if there's any complications, anything like that. So we will check the patient record for all of those things before we do the procedure. So when a patient comes in the morning to drop off and check in for a surgical procedure, there are two forms that we go over with them. The first form is our drop-off and surgery form. So we go over this with the client. Questions on here, firstly, is if your pet has been fasted. We do require them to be fasted by at least 9 p.m. the night before the procedure, so we'll double check to make sure that they have been fasted. We also ask if they are on any medications currently, what medications they're on, and we'll just double check that with the client. For the form that they need to fill out, The first question right here is a DNR, so we do ask them if they would like us to perform CPR in case of an emergency, or if they do not want us to perform CPR. If they do not want CPR, then they would go ahead and initial here. If they do want CPR, then they leave it blank. Next questions is if anything pops up, say that is not on the treatment plan, which I'll go over in a second, do they want us to go ahead and do what's necessary, or they want a phone call first? So they'll initial either one. They'll initial either like, you do not have to contact me, do whatever's necessary, or they'll initial, please call me for any additional procedures. And then they will put the preferred phone numbers for us to contact here. The next, this right here is just listing out any procedures that the client has agreed to for that day. So if it was a surgery, say like for Juniper, this form is for Juniper. She is a 4-month-old female domestic short hair feline. So for Juniper, she is getting a spay, so we would put spay here. And then if she wants her microchip, then we would write the microchip on here as well. And then it goes over pain medication, so she would get injectable pain medications in hospital, as well as take oral pain medication home after the procedure. And then it goes over pre-anesthetic blood work and why it's important. That is on here as well. On the back, we have lab work. If they approve or decline lab work, so that would be if we are sending off a biopsy, are they approving or declining the biopsy, they would initial one of these stating if they approve or decline. Next, we will go down here. This is stating if they have any fleas, we do have to treat them in the hospital that day at the cost of the client. So they would have to initial this. It's just hospital policy. This right here is stating if the pet is not picked up by 6 o'clock, which is when we close, the pet will be staying overnight, and there is an overnight fee. And so the client does have to initial that as well. And then they have to sign at the bottom and date, and then the staff member that's checking in the patient signs at the bottom as well. The other form that we go over with them is their treatment plan. So for example, this one for Juniper, she would be getting spayed. So we would go over this with the client the morning of the procedure. So just to go over it really quickly, this right here is the cost of the procedure. Everything that is zeroed out is included in that cost. So this includes obviously the pre-surgical exam, her catheter, fluids, intraoperative, her Cerenia injection, pain injections, the surgical monitoring fee, the anesthesia fee, on Stewart to go home, and then a nail trim is included as well. The only things on the treatment plan that are not included and do cost extra is the e-collar, which they can decline if they like, if they have one at home already, but we do encourage them to take an e-collar home. And then the other optional thing is the microchip. So they can either choose to microchip their pet or decline it at the time. And then we would just have them sign at the bottom. And then both of these forms would be scanned in and attached to the patient's profile. So if we go here, so for example, this is a patient that had a procedure done today, so she did fill out this paperwork this morning. So if we go to this patient's profile and we go to attachments, you can see under the soap notes, we did attach the paperwork that she filled out this morning. So we scanned it in and attached it. After going over the intake forms with the client, we then ask if they have any questions about the procedure. We do briefly go over the procedure with them. So for example, if Juniper is having a spay on that day, we will go over it with the client. We will let them know that the doctor does 3 or 4 surgeries a day, so we don't know where Juniper is going to fall on that line, but at the time of her intake, we will go ahead and bring her to the back, place a catheter. At that time, the doctor will do her pre-surgical exam, and then we would go ahead and either pre-medicate, depending on if Juniper is going to go first, we would go ahead and pre-medicate her, and then whenever the doctor is ready to start, we would take her into the surgery room. We would give her an induction agent, intubate, and then the doctor would come in. She would be monitored throughout the procedure. Doctor would come in, perform the procedure while the patient's under general anesthesia, and monitored throughout. And then we would recover her, and we would monitor her for the next few hours, keep her on IV fluids, and then the doctor will know, will let the client know when the patient is ready to go home. And then I ask if the patient has any, or if the client has any other questions or concerns. If it's a spay or neuter, we do tattoos here for spays and neuters, so we do go over that as well, and just let them know what that consists of, why we do it. They can choose to decline that as well. If they do not want the castration tattoo on their pet, they can decline that as well, but we'll just go over it with them and make sure that they're okay with that. And then we'll just ask if they have any other questions or concerns about the procedure for that day. So any patient that's coming in for a surgical procedure would go in these kennels right here. We usually only do 3, maybe 4 procedures a day. So if they are getting a surgical procedure, they go in these kennels here because they are in the treatment area, so it's easily access to monitor them. We see them as they're recovering, when they're pre-medicated, all that stuff. We're able to monitor them easier with them out here. To identify the patient, they do get cage cards. So for these cage cards, we do print out their patient label. Their patient label does have their first and last name on it, as well as the client's information. It goes over their breed, their color, their date of birth, their weight, and their age. So we will print this out. We do also put the date of the day that day, and then the procedure that they're going to be having. And then once they come in for their procedure, we set up their kennel with their kennel card. We do go ahead, we put them on this whiteboard over here. We do have a surgery tab over here, so they will go under surgery. So we go ahead and write them on the board. We put their the patient's name, last name, their weight, their temperature, and then all of the things that they will be receiving that day. So we put the pre-anesthetic exam, their IV catheter and fluids, their pre-medication, and what time we pre-medicated them, the procedure that they're having, as well as anything else such as medications, charges, and all that stuff as well. We'll all go on this board so we can mark it off throughout the day. So other forms needed during a surgical procedure would be if you're doing a biopsy, we would have to send a requisition for that biopsy to the reference lab. So you would go into the patient's profile and you would put in the line item for a biopsy that you're performing. So if we're just doing one site, we're just biopsying one site on a patient, we would check one or select biopsy with one site, and then it's going to pop up, do you want to create a requisition? And you're going to click yes. This box is going to pop up for IDEXX. You're going to have to put in the specimen details, so we're going to click that. It's going to pop up with everything that you need to put in for this biopsy. For example, it's going to ask you the sample source, so you do need to put that. So if it's, for example, we took off a tumor, a subcutaneous tumor, we would click the subcutaneous. You'd have to put in the sample type, whether it's excisional, incisional, it's a needle biopsy, anything like that. Say we took off the whole tumor and we're sending the whole tumor, we would do excisional, and then you have to put the location from where you took the tumor. So say we took it from her left shoulder, we would click where we took it from, her left shoulder, and then we have to put clinical history, so how long the tumor has been there, how fast it grew, everything that we know about the tumor on our end. That would all go in this box here. So okay, so this would also include like any notes from the doctor about the tumor, about her margins, anything like that. That would all go in this box. click done, and then we would have to click order, and then it would generate a requisition for us. We would print out 2 of these, so one would go with the sample to the lab, and then the other requisition would stay here in hospital for us to reference if needed. For discharge instructions, we do use the same discharge paper for all of our surgery patients. So it goes over basically everything that they need to know after a surgical procedure. So we would highlight whatever applies to them basically. So on here, first off at the top is just stating proper restraint in the lobby. Cats need to be in a carrier, dogs need to be on a leash. And then we have their diet instructions for after the procedure. For a spay or neuter or like a soft tissue surgery, something like that, they would feed the regular diet with restrictions. So they would feed small increments of food and water over the next 8 hours, just because
we have Bentley here for Dr. Hooker. Bentley for Dr. Hooker.
So they would offer small increments of food and water just for the first 8 hours after the procedure, just because if they eat or drink too much, they may vomit. It may cause vomiting. And then after that, they can return to their normal feeding and water consumption unless otherwise instructed. Or we have the option to feed multiple smaller meals however many times per day, and we also have special diet instructions. So for special diet instructions, we would have to put specifically what the doctor is asking for. So for example, for dental procedures that have had extractions, generally they will need to feed a soft food diet for the next 14 days. So we would go ahead and write that in here. Next is their eliminations. We do let them know that they may not have a bowel movement for 24 to 36 hours due to there can be temporary GI stasis after receiving anesthesia, and that can be normal. If it lasts longer than 36 hours, then please call us and let us know. For exercise and activity, this is going to vary depending on what procedure we did. But for example, if they had a spay or a neuter or like a soft tissue surgery, they are going to be restricted exercise, or avoid access to stairs, and then they cannot bathe or go swimming for 14 days, and then they do need to check the surgical site for any swelling, discharge, redness, after the procedure, anything like that. And then we do put on here they can resume normal activity in 14 days. Again, 14 days may change depending on what we did. And then they do need to be confined to indoors for 14 days. And then they need to be under strict confinement to a cage or small room for 14 days. And then down here we have their medications that they'll be going home with. For example, Juniper is going to go home with Onstore. So we put Onstore 6 milligrams. We put the milligram dosage that they're taking home, and then we put the instructions. So she would get 1 tablet every 24 hours. We also put when they start that medication. So she would start that tomorrow morning. If she had the injection in hospital today, then she wouldn't start that Onstore until the following morning. And then we do let them know any side effects. So for Onstore for cats, it would be anorexia, vomiting, diarrhea, lethargy. For dogs, we generally send home Rimadyl. So for that, we would look for anorexia, vomiting, diarrhea, melena, or seizures for Rimadyl. And then for their sutures, we do put on here, discourage them from looking at the incision site, check it daily. Generally for spays and neuters, they're not going to have any external sutures. It's going to be internal absorbable sutures. So we do put on here, if it's external sutures, then we would mark suture removal in however many days. Typically that would be 14 days. So we would put suture removal in 14 days. If their sutures are absorbable, we're going to check the sutures are absorbable. and don't need to be removed. Or if we didn't do sutures, then we would put there are no skin sutures. In this area here, this is stating when they need to come back. If they need to come back for a suture removal, drain removal, bandage or splint change, or if they need to come back for a recheck appointment, that would go in this area here. Here, this is what they need to be monitoring for. So over the next 1 to 2 days, they need to monitor for loss of appetite, refusal to drink water, weakness, depression, vomiting, or diarrhea. Over the next 1 to 2 days after the procedure, if their pet experiences any of those things, we do suggest they call us and let us know. And then we do have the e-collar instructions on here that they do need to wear an e-collar at all times for the next 14 days if they have had like a soft tissue procedure such as a spay or neuter. And then
Pearl here for tech time. Pearl's here for tech time.
we have the special instructions box. So if the doctor has any other like specific instructions for the owner, that would go here. And then we have a microchip. So if the patient received a microchip that day during the procedure, the microchip number would go here. We're going to show how to restrain for blood draws. So for a jugular draw, you'll have your patient in a sitting position. You want to put your knees right behind their shoulders, that way they can't back up. You're then going to hold their head just right under their jaw line, so you'll hold it firmly, and then you'll kind of lift their jaw upwards. That way the whoever's drawing has access to their jugular veins. And then for a cephalic draw, you can have them either in a sitting position or in sternal recumbency. You will grab their front leg and extend it, and then you're going to take your thumb and you're going to roll outwards. So again, to occlude the vein, you're going to take your thumb and you're going to roll outwards. That way that occludes the vein and presents the vein for whoever is drawing. For a lateral saphenous draw, you will have them lay down laterally. And you'll restrain them in a lateral recumbency. You'll restrain them in lateral recumbency. The lateral saphenous vein runs along the back leg right here. To occlude that vein, you're going to hold off on the upper portion of the thigh. That's going to occlude the vein and present it for whoever is drawing. This is Whaler. We're going to show how to properly place him in a kennel. So you will open the cage of the kennel. You're going to let them walk into the kennel, and then you're going to remove the lead, and then you'll also remove any belongings that they have on them, any collars, anything like that. And then you want to latch the kennel door, pull on the door to make sure that it is closed. To remove them from the kennel, you're going to take a slip lead, open the kennel door just slightly, place the lead over their head, and then open the door and let them walk out. And then again, close and latch the kennel door. Okay, and to properly place a muzzle, you want to stand behind the patient. You're going to take your muzzle. You want to make sure it's an appropriately sized muzzle. You want it to fit a little snug. You don't want it to be super tight, but you do want it to fit a little snug. So you want to make sure you have the correct top of the muzzle. So the top portion of the muzzle is here. It's going to go right over the bridge of the nose. So you're going to stand behind your patient. You're going to come behind them. You're going to slip the muzzle over their nose. The straps are going to go behind the ears, just behind the ears. You're going to latch the latch on the muzzle, and then you can tighten it if it needs tightened. And then that's how to properly place a muzzle. To place an Elizabethan collar on a patient, So you want to make sure you grab a appropriately sized e-collar. You do want to make sure that the edge of the e-collar extends past their nose. If it does not extend past their nose, then they may be able to get to the wound or incision site. So you're going to take the cone and you're going to sit. Good boy. Come on. Sit. You're going to take the cone. You're going to come behind the patient. You're going to wrap it around their neck and you're going to measure. The same way you would do a collar, you want to be able to fit at least 2 fingers in between their neck and the cone. So for him, I can go a little bit tighter. Okay. And then depending on the type of cone that you have at your hospital, for ours, it has these little slips that go through these slots. So you would have to put the cone together, loop these slips through the notches on the e-collar. After you have done that, it will look, sit. Here, come on, up. After you've done that, it will look like this. So to place it on the patient, you'll slip it around their head like this. Their ears need to come through as well. And then you'll take a ribbon or some stretch gauze like this, and you're going to tie it snugly, not too tight, snugly around their neck as such. And then you want to make sure that they're not going to be able to get it off. This is Whaler. We're going to be doing a pre-anesthetic exam on him. He is getting a dental done today. He is a 5-year-old neutered male Labrador Retriever mix. Like I said, he is getting a dental done today. We're going to do his pre-anesthetic exam, starting with his temperature, pulse, and respiration. For temperature, we're going to be doing a rectal temperature. We'll be doing a rectal temperature with a rectal thermometer. We will place some lubricant on the thermometer before placing it in the rectum. And our temperature is 100.2, which is normal. For pulse, you will be taking the pulse at the femoral artery, which is located on the inside of both back legs. So you will locate the femoral artery. You're going to apply pressure gently with your fingertips, and then you're going to count how many pulses you get in 15 seconds and multiply it by 4. Okay, so I did get 22 pulses in 15 seconds, so multiplying that by 4 would be 88, so 88 pulses a minute. And then we'll take his respiration, so you're going to take how many breaths he's taking in a minute. He is panting, so we will notate his respiration as panting. Okay, we're going to start with his physical examination. So first we're going to look at his eyes. So his eyes do look normal. I don't see any discharge. The conjunctiva isn't red, anything like that. He does have normal palpebral reflexes. Next, we're going to be looking at his ears. Ears look just slightly waxy, but I don't see any redness or any black gunk or anything like that. Then we're going to be looking at his nose. So we'll look at his nasal cavities. They do look average. I don't see any discharge. I don't see any blockages in the airway. We're going to go ahead and look at his mouth. We're going to go ahead and look at his mouth. Okay. Mouth looks normal. Teeth have mild tartar accumulation, so he's about a stage 2 out of 4 for dental staging. I don't see any fractures on any of the teeth, and I don't see any teeth missing. And then for capillary refill time, we're going to occlude blood flow to the gums. and then count how many seconds it takes for the color to return. His is less than 2 seconds, which is normal. His mucous membranes are pink and moist, which is normal as well. If they were tacky, that would be dehydration. If they were pale or red, that would be abnormal as well, so we would report that to the doctor. We're gonna check his lymph nodes for any swelling or firmness. Stand. Okay, lymph nodes feel normal. I'm not feeling any swelling or anything like that. Okay, next we're gonna check his range of motion. Not there. Good boy. Good job. Range of motion is normal. I'm not getting any popping, anything like that. I'm not getting any resistance from him, so I would say his range of motion is normal. Next, we're gonna check his skin and coat. His coat looks pretty normal. I'm not seeing any hair loss, anything like that. He does have a history of skin allergies. There are just a few scabby lesions on his abdomen. Like I said, he does have a history of skin allergies, so it could be due to that. We will notate it to the doctor before his procedure just to let her know. But to continue with his exam, his coat looks good. Like I said, not seeing any hair loss, anything like that besides normal shedding. We're gonna go ahead and listen to his heart and lungs. And when we listen to heart and lungs, you do want to listen on both sides of the patient. For the heart, you do want to listen to make sure that they have a normal rhythm and a normal sounding beat, so a lub-dub beat, which he does. I'm not hearing any swishing, any arrhythmias, anything like that. So heart sounds normal. For lungs, you're going to be listening for any crackles, any obstruction of the airway, anything like that. I'm not hearing any of that for him. So again, his lungs do sound normal. We're gonna go ahead and palpate his abdomen. Come here, bud. History-wise, he has had 2 foreign body surgeries. So he has had his abdomen opened twice. Abdomen feels fine. It doesn't feel tense or distended. So abdomen feels pretty normal. We're gonna go ahead and look at his rectum. Rectum looks normal. I'm not seeing any swelling or redness of the rectum, so that looks good. We're gonna take a look at his prepuce area. Prepuce looks normal. I'm not seeing any discharge or any abnormalities with the prepuce. Again, he's been neutered, so he doesn't have any testicles. Body condition score-wise, he looks really good. He doesn't have too much fat coverage over his ribs. He has like a normal amount. He has a nice tuck up in this area. So I would say he is at a body condition score of 5. For pain, he doesn't seem to be in any pain. He does seem a little nervous, in hospital, but doesn't seem to be painful or anything like that. For his ASA rating, his blood work was within normal limits. We are only 5, we're not a senior dog or anything like that. We have no known history of any issues with anesthesia. So for ASA rating, I would rate him at a class 1, so a low level of risk. And then again, abnormalities that we know of is his skin allergies, no abnormalities in blood work, and then he has had 2 foreign body procedures in the past, so he definitely could have some abnormalities in his abdomen or in his intestines, which we will let the doctor know about. This is Ivan. He's a 6-year-old neutered male domestic short-hair feline. We are going to be doing a pre-anesthetic exam on him today. So first, to get started, we're going to be doing a TPR. So that's temperature, pulse, and respiration. So I am going to grab his temperature rectally with a rectal thermometer. We're going to put a little bit of lubrication on the thermometer, and then we're going to take his temperature rectally. So temperature is about 101.0, which is normal. So for pulse, we are going to, generally the pulse is taken from the femoral artery, which is located on the inside of the hind legs. So we're going to palpate the femoral artery for the pulse. We're going to count how many pulses we get in 15 seconds and then multiply it by 4. So I did get 88 pulses in a minute, and then for respiration, we're going to count how many breaths he takes in 15 seconds and then multiply that by 4 as well. Okay, so we did 10 breaths in 15 seconds. That would be 40 breaths in a minute. Next, we're going to go ahead and take a look at his eyes. Eyes look good. I'm not seeing any discharge, redness, anything like that. His palpebral reflexes are normal. For his ears, we're going to take a look at those. Ears look normal. They're not red, irritated. I don't see any gunk, anything like that. And then nose, we're going to check his nose. Okay. Airways look clear as far as nasal cavities go. I don't see any discharge from his nose. And then we're going to check the inside of his mouth. So he does have a history of stomatitis. All of his teeth behind his canines have been extracted, so he does not have any teeth behind his canines. His remaining teeth, his canines and his incisors look good. I don't see any fractures or any tartar buildup on those. And then we're going to check his capillary refill time. So we're just going to apply pressure to the gums and count how many seconds it takes for them to return to a normal color. His is about less than 2 seconds, so I would say that is normal. We're also going to check his mucous membranes. They are pink and they are moist as well, which is normal. If they were pale or red, that would something that would need to be reported to the doctor. If they were tacky, that could indicate dehydration and would need to be reported to the doctor as well. So next we're going to palpate his lymph nodes. Lymph nodes don't feel swollen or anything like that. I would say lymph nodes are normal. We're going to check range of motion. Good kitty. Normal there. Good kitty. Normal there. Turn back. Good kitty. Okay, there. Check the back. back legs, but it could be because he just is a little nervous. Stand up, kitty. Okay, we're a little shy for our back legs, which is fine. We'll just keep note of that. And then next would be skin and coat. His skin and coat looked pretty normal. I don't see any ectoparasites, any fleas or ticks. His coat is shiny, it looks pretty healthy. There's no redness or irritation to his skin, anything like that. And then we're gonna go ahead and we're gonna listen to his heart and lungs. Heart sounds normal, the normal loved up sound. I'm not hearing any swishing, any murmurs, anything like that. I'm gonna listen to his lungs. Lungs sound normal as well. You do want to listen to both sides of your patient for heart and lungs, which we did. Lungs sound normal. I'm not hearing any crackles, anything like that. I'm hearing normal airflow through his lungs, so we are good there. I'm going to go ahead and palpate his abdomen as well, just to make sure we're not tense. We don't have any pain in the abdomen. Abdomen feels normal. I'm not feeling any tension, anything like that. So I would say we're probably not painful in our abdomen. Next, we're going to check our rectum, just to make sure everything looks normal. Everything looks normal. I'm not seeing any swelling or redness or irritation to the rectum. Next, we're going to check our body condition score. He is a little on the heavier side. I would say body condition score, he's probably a 6, so not too overweight. Just a little bit of extra fat coverage. And then pain-wise, I would say he doesn't seem to be in any pain. He seems a little nervous and a little tense. Just being in hospital today, but I don't believe he is in any pain. We do see him quite often. He is a nervous cat in the hospital, so I would say that his tenseness could be due to his nervousness. Okay, we have completed our physical examination. There weren't any abnormalities noted on blood work. His blood work was all within normal limits. Again, the only diagnosis to be aware of is that he doesn't have any teeth past his canines. But other than that, he's pretty healthy. He's not a senior pet. I would say as far as his ASA rating, he's probably a class 1. And then if there were any abnormalities that would need to be reported, that would be something such as any abnormalities on his blood work. If we heard any like swishing noises or abnormal rhythm of the heart, if we heard any crackles in the lungs, things such as that, they may need further diagnostics, and we would have to report those things to our doctor. Okay. Now we're going to be doing a cephalic draw on a canine patient. I am going to occlude the vein by rolling off at the top of the leg up here. The cephalic vein runs right along the top of the leg here. I'm going to make sure my bevel is up. I'm going to go in at a 30-degree angle. And then draw back. And then I'm going to hold off on the puncture site for 30 seconds. Okay, we're going to be doing a cephalic draw on a cat. The cephalic vein runs right across the top of the front legs. So we're going to wet the area with some alcohol. You're going to palpate for your vein.
Let's turn on the light.
That right there is a little lateral.
Yeah.
Okay, once you've located your vein, you're going to make sure your bevel is up. It's okay, Kitty. You're going to puncture at a 30-degree angle. Okay. And then once you have punctured the vein, you'll draw back on your syringe. And then you'll hold off on the puncture site for 30 seconds. Okay, we have Wayler here today. We're going to be doing a jugular draw on him. So we'll have him in a sitting position. I'm going to occlude the vein by holding off at the thoracic inlet. We're going to palpate for his jugular vein. Once we find it, we're going to apply some alcohol. You're going to take your syringe. You're going to make sure your bevel is up, and you're going to puncture at a 30-degree angle.
And I stuck my nose in her ear.
Once you've punctured the vein, you're going to draw back on your
and then when I went
plunger.
to take her temperature, she anal glanded a little bit and goes, "That's the smell." I was like, "Let me do her anal glands." So got her anal glands. Her anal glands were pretty full.
We're going to be doing a jugular draw on a cat. First, we're going to hold off on the thoracic inlet to occlude the vein. You're going to palpate for your vein, and then once you locate it, you're going to wet the area with an alcohol gauze. And then taking your syringe, you're going to make sure your bevel is up, and then you're going to puncture at a 30-degree angle. Oops. And then once you have located the vein and punctured it, you'll draw back on your needle, on your syringe. And then you'll hold off on the puncture site for 30 seconds. All right, we're going to be doing a medial saphenous blood draw on a cat. So you will wet the area with some alcohol. Once you locate your vein,
Can you come tap his head?
you're going to take your syringe, make sure your bevel is up. We're going to puncture the vein at a 30-degree angle. And then once you have punctured the vein, you're going to draw back on your syringe.
You're literally right there.
Good job, kitty.
Okay, so we're going to be talking about some minimum databases needed before a surgical procedure. So this would be included in your blood work, which you would be looking at your packed cell volume, your total solids, your blood glucose, your blood urea nitrogen, and your alanine aminotransferase. To start, you'd look at your PCV, or your packed cell volume. This is the percentage of whole blood that is made up of red blood cells. Low PCVs could indicate chronic renal failure, autoimmune diseases, parasite infection, or blood clotting disorders. Obviously, if you have a blood clotting issue, you don't want to open that patient up in surgery because their blood is not going to clot properly, and that could be a major concern. So if they have some type of blood clotting issue, we may reschedule the procedure or cancel the procedure altogether, just depending on the patient and what we can do for them. But if you have an increased PCV, that could indicate dehydration, and at that point we may take a look at their fluids and see if their fluids need to be adjusted or what have you. Next, you have your total solids or your total proteins. So this provides info on your patient's plasma protein levels, which would include albumin, globulin, and fibrinogen. These levels have a direct effect on your serum onconic pressure. So low levels have a direct effect on low serum onconic pressure could result in edema, and high serum onconic pressure basically the fluids shift out of the interstitium and back into your blood vessels. So your plasma protein levels are important because some anesthetics are highly bound to your proteins, so the dosages may need to be adjusted. Next, you have your blood glucose, which is very important in your juvenile and your diabetic patients. This indicates carbohydrate metabolism and measures the endocrine function of the pancreas. So in some, if you're diabetic and your juvenile patients, their blood glucose may need to be monitored throughout the procedure because blood glucose can be directly affected by stress. So of course, like doing a surgical procedure can have stress on a patient. So if you have one that is diabetic or prone to increased glucose levels, then those may need to be monitored throughout the procedure. Next, you have your blood urea nitrogen, or your BUN. This is used to evaluate the kidney's ability to remove urea from the blood. Some anesthetics are primarily metabolized by the kidneys. So if the patient's renal function is compromised or their kidneys are compromised, then drugs that are not primarily metabolized by the kidneys may be considered. After that, you have your alanine aminotransferase, or your ALT. This is an enzyme that's found in high concentration in the liver cells. Some drugs that we use in hospital, such as anticonvulsants or corticosteroids, could affect these levels. So if you have an ALT that's already elevated, then that should be taken into consideration. So we've already discussed some minimum databases that we would need before surgery. So an establishment exam, any previous diagnoses, vaccines, pre-anesthetic blood work, anything like that would be minimum. For extra databases that we would need, say if the patient has any heart disease or heart murmur, we would need to do at least radiographs before the procedure to check for enlargement of the heart or any fluid around the heart. Sometimes we would even do an ECG before the procedure just to check to see if anything is drastically abnormal there, then we may not proceed with the procedure. Say if they have any abnormalities on their blood work, like maybe their platelet is very low, we would do a manual platelet count. So we would stain a blood smear and count the platelets manually, just to double check that. If they have a really low platelet count, then we would probably reschedule the procedure and possibly do further testing for that. Okay, now we're going to go over the appropriate peri-anesthetic and anesthetic protocol for patients. We use a combination of drugs such as sedatives and pain medications to ensure that our patients remain relaxed and not stressed going into anesthesia. And then also like transitioning into general anesthesia, make sure that they are appropriately, like their pain levels are appropriately managed as well. And then transitioning out of anesthesia into recovery as well. So for our hospital, we have several different drugs that we can use for perioperative medications. So for example, I have Juniper's drug sheet. For her, she's a cat, so we would be using butorphanol and midazolam, as well as Cerenia. We also have hydromorphone. We don't tend to use that in cats too often, just because it does cause significant nausea in our cats. So we tend not to use hydromorphone in our cats. We do use it more often in dogs for extensive procedures or procedures we will be going into the abdomen, or for example, if they're having a dental with extensive extractions, then we would use hydromorphone. We use Cerenia on every patient. We generally like to give it about 15 to 30 minutes before we give the other preoperative medications. So they will get a dose of Cerenia, and then about 15 minutes before we're ready to start the procedure, we'll give the pre-meds, which for Juniper would be the butorphanol and the midazolam. The butorphanol is going to act more as your pain management, and the midazolam is going to act more as your sedative, just to keep her calm and stress-free. And then we would go into surgery, and that's when we would follow up with the induction agents afterwards. So it is really important to have good perioperative pain medications and sedatives on board, as well as anti-nausea medications, like I said, just to make sure that the transition into surgery remains stress-free and pain-free for the patient. Okay, so we're gonna record our controlled drugs into our controlled drug log. So we're gonna do alfaxolone. So if you look at our controlled drug log, we have the drug name up here, as well as the strength, which is 10 milligrams per mil. This is a new page, so all we have on here is our last inventory check with how much we had on hand. So we're going to go ahead and put in the alfaxolone that we used for Juniper. We used 0.9 mils of the alfaxolone. So we're going to put the date. We're going to put Juniper's first and last name. We're going to put the reason that we used this medication. We're going to put the amount that we used. And then we're going to take the amount that we used today and subtract it from our previous amount on hand. And then we're going to put our initials. So if you look here, we have today's date, our patient's first and last name, the reason why we pulled up this controlled substance, the amount that we pulled up, and then the balance that we have on hand now, and then our initials. Now we're going to go over our anesthesia machine and how it works. This is one of our anesthesia machines. It is connected to an oxygen line, which we will go over the oxygen tanks here in a little bit. Down here. Okay, so to start, this is our vaporizer. This is where the ISO is kept, and the oxygen basically flows into this vaporizer and turns the isoflurane into a gas inhalant, which is the anesthetic that we use for our patient. It does have a gas flow gauge right here that we can turn. Right now it's off. To turn it on, you would press this white lever, and you can turn it all the way up to 5. Or turn it off if needed. There's also a window right here that tells you how full the isoflurane liquid is. If it was getting pretty low, there's a low line. If it's getting down to that line, we would open this chamber right here, and this is where you would fill it with more isoflurane if needed. Okay. Next, this is our oxygen flow meter. This controls the oxygen flow rate that the patient is receiving. So you turn this knob here to change the oxygen flow rate. There's also a oxygen flush valve right here that can be used to flush oxygen through the system. These are our inspiratory and expiratory valves. So whenever our patient inhales, it's going through this valve here. There is a little white piece of plastic, circular piece of plastic in here. Every time the patient inhales, the little white piece moves up and down. So whenever the patient is inhaling, this valve opens up. The patient inhales. Whenever the patient exhales, this valve closes, and it will go over here until to the exhalation valve. So when the patient exhales, this little round piece of white plastic opens up over here when the patient exhales to allow for one directional flow. That way, if the patient exhales, we're not getting any backflow here. And then when they inhale, they're not getting any backflow from the exhalation valve. So it's all one directional flow. So just continuing along, this canister right here is our soda lime canister. This is our carbon dioxide absorber. So every time the patient exhales, it goes to this canister here. It is filled with soda lime crystals. These crystals do change color as the carbon dioxide is absorbed, and they do turn purple as a reaction of absorbing that carbon dioxide. We can only use the soda lime for up to 8 hours, and then it needs to be changed. So we do keep track of how long our patients are using, or how long our patients are under anesthesia, and we will keep track of it here on this little chart here. Once it has reached 8 hours, we will go ahead and dump out the old soda lime and switch it out for fresh soda lime. Next, we have the negative pressure relief valve. This is basically a safety feature. So this acts as a safety feature if there's any negative pressure within our system, say our oxygen source is depleted. This is going to act as a negative pressure relief. So it's going to allow room air or room oxygen into the system if something like that were to occur. So this basically stays open at all times. We don't ever close it. Like I said, it is there for safety wise, just in case anything were to happen. If negative pressure were to build up in our system, that could be detrimental to our patient. So this acts as the safety backup for that. Okay, and this right here is basically our pop-off valve. Kind of acts the same way that the negative pressure valve does. You're going to hold this off to temporarily build up pressure, and then release it to open it and allow basically ventilation. So it does the same thing as this. It's just more quick release, like temporary pressure and release, rather than screwing this open and closed. Also with this, you're not going to forget to open it back up. So this is a little bit safer than using this, but we will sometimes use this rather than this when we're doing like leak testing. Next, for our scavenging system, down here you can see we are attached to a charcoal canister. Some hospitals have a scavenging system that is built in to the hospital. We have a passive scavenging system. So basically any of our anesthetic waste is going to be absorbed by this charcoal canister. We do have to weigh the charcoal canister before and after every procedure. When we obtain the canister, we do go ahead and we weigh it in grams, and we write how much it weighed before use. And then once it has increased by 50 grams, that means it needs to be replaced. So we would go ahead and toss this once the grams have increased by 50, and then we would replace it with a fresh one. Okay, now we will go over our breathing circuits. So this is a rebreathing circuit. These are useful because they allow some recirculation of anesthetic gases, which allow for a lower oxygen flow rate for the patient, because some of the gases are being rebreathed, hence rebreathing circuit. So this end here would connect to the endotracheal tube. This end here connects to the inhalation valve, and then this end here connects to the exhalation valve. The rebreathing circuit that you choose is going to depend on the size of your patient as well. The red rebreathing circuit is going to be used for patients between about 16 to 35 pounds. That is a rough estimate. Of course, you are going to have to decide the rebreathing system based on several factors, such as if your patient's overweight, their lung capacity is going to remain the same regardless if they're overweight, so you need to take that into consideration. But a rough estimate for the red rebreather would be between 16 and 35 pounds. Then we would use our blue rebreathing circuit, which is slightly bigger for patients over 35 pounds. You also have your reservoir bags. The size of the bag, which they come in liters, so this is a 1 liter bag, but the size of the bag would change depending on the size of your patient and their lung capacity. The purpose of this bag for our rebreathing system, one is going to help with the rebreathing of gases. It will fill up as the patient exhales, and it will close in as the patient inhales. So you can use it to count respiration rate in that sense. It also can be used to aid in manual ventilation for the patient. So if you have a patient that is not breathing at all or not breathing very frequently, you can use the reservoir bag to manually ventilate your patient. And then we have the pressure gauge. The pressure gauge is basically an indicator to the pressure in the patient's lungs. So next we're going to talk about our non-rebreathing system. So this system would be used on patients that are less than 15 pounds. The advantages to using the non-rebreather system is that the patient is going to have less resistance, so less like low gas resistance, which makes it easier for them to breathe. And then they're also going to have a constant flow of fresh gas because their gases are not being recirculated with this system. So to hook up this system, basically we're going to detach this from our charcoal. And I didn't mention earlier, it is important that your charcoal remain off of the ground because it does need air circulation and air ventilation to work properly. So it is important to have your charcoal off of the ground. We're going to connect this side to our charcoal. That's going to be our gases are going to absorb to our charcoal that we exhale. And then this part is going to be hooked up to our oxygen. So we're going to unhook it, this part from our soda line. And we're going to basically need this part here. This is going to be directly our oxygen and isoflurane. It's going to come through here. So we're basically bypassing the CO2 absorber and the pressure gauge. So we're not going to be using those things. We're not going to be using this reservoir bag either because our non-rebreathing system has its own reservoir bag. This reservoir bag is 1 liter. It's always going to be 1 liter because you're using it on smaller patients. The non-rebreather also has an open and close valve. So you want to make sure that it is open whenever you have it hooked up to the patient, which we would have this end here hooked up to the endotracheal tube. But you want to make sure that you have it open. That way the patient is able to breathe in and out. If you close it, you do need to manually ventilate for your patient. If you leave it closed and you don't reopen it, this will continue to fill and it's going to build up pressure in your patient's lungs. So we want to make sure that it does remain open unless you are manually ventilating. So if you're manually ventilating, you'll close it, give your patient a breath, open it again. And then if you need to give another breath, you're going to close it, give your patient a breath, and then open it again. Okay, and then we have anesthetic and oxygen masks. These do come in several different sizes. So basically we use these for any patients that can't be intubated, that we need to induce or give flow by oxygen or something like that. We will use these masks for them. These do tend to leak though, so they can leak anesthetic gases into the room. So these cannot be used for an extensive amount of time. They're mainly just temporary if you're going to be using anesthetic gases with these. We then have an inhalation chamber. This is basically used for any fractious cats or small patients. So basically, you would put the patient in the chamber. You would hook up the anesthesia machine to the tubing here, and it would fill the chamber with either anesthetic gases or oxygen, because this also can be used as an oxygen chamber as well. But if you're using it for induction, it would fill the chamber with anesthetic gases, and then you would basically wait until the patient was unconscious before removing them from the chamber. So then you could place an endotracheal tube or whatever you needed to do with the patient then. Okay, so our oxygen supply is located in a storage closet outside. So we do get 3 oxygen tanks. They come full. They come with these little tags that will say full, in use, and empty. Once one is in use, we rip off this full part to indicate that this is the tank that is currently in use. Once one has been completely used up, we'll rip off the in-use tag, and it will be left with the empty indicator. That lets them know that it does need to be replaced. For the oxygen tank that we currently have in use, we have the oxygen pressure gauge hooked up to it. This tells us how much oxygen is left in the tank. This valve here is used to turn the oxygen on and off. We do check this in between procedures, before procedures, and in between procedures, just to make sure that it is still has enough oxygen in it, because we don't want to run out of oxygen while we have a patient under anesthesia, because we need oxygen to run through the vaporizer for the anesthetic gases. So whenever it's time to change an oxygen tank, we will remove this portion here from the tank, and we'll connect it to the next tank here. So we just move it to whichever tank is the next one in line to be used. The next one that is full. Okay, so before any anesthetic procedure, you want to perform a leak test on your machine. This is really important to make sure all of your equipment is working properly. You don't want anything leaking. You don't want anesthetic gases leaking. You don't want there to be a leak in your tubing or in your reservoir bag. So we are going to do a leak test before every procedure. To do this, you want to first make sure everything is hooked up properly. So our oxygen line is hooked up, our tubing is hooked up properly, we have our reservoir bag hooked up properly, and then our scavenging system is hooked up properly as well. So to start, you do want to close the pop-off valve all the way, so we have it closed. You're going to occlude your tubing with either your thumb or your palm. And then you're going to fill up your reservoir bag by pressing the oxygen flush. And you want to fill it to about 20 centimeters on the pressure gauge. And then you're going to watch and watch to see if the pressure gauge starts to drop. If it drops more than 1 centimeter per second, then you know you have a leak. And then you will need to check everything. Maybe change your tubing, your reservoir bag, check your line, all that stuff, your CO2 absorber, make sure it's screwed all the way in. So ours is holding pressure, so we don't have any leaks. So I'm going to go ahead and release the tubing. Next, we're going to place our pulse oximeter or our SpO2. This does need to go on a mucous membrane or a toe, something like that. We are going to place this one on her vulva. Your pulse ox will read the oxygen percentage in your blood. It will also take your respiration as well.
Good.
Okay. So we're gonna go ahead and place the esophageal probe on our patient. So first we're gonna measure. You don't want to measure just right behind the elbow. That's where the area of the heart is gonna be, which is where you want your stethoscope to go. So you're gonna measure right behind the elbow, and then at the canine, so you know how far in your stethoscope needs to be placed. Since she has an endotracheal tube already placed, the only place for this to go is the esophagus. So we're gonna go ahead and advance it into the esophagus. And we have it, we know right here is about where we need to stop. Okay. And the esophageal stethoscope basically acts as a sound amplifier for the heart. So generally it's going to be connected to either an amplifier or earplugs, so it amplifies the sound. Ours is connected to our monitor over here, as you can see. On here, it's going to give you the electrocardiogram, but it's also going to beep every time the heart beats. That way you can hear the actual heartbeat of the patient. So for gastric intubation, you would use a gastric tube like this. You place it similar to how you would place an esophageal probe. It's going to go into the esophagus, but you would measure to the last rib instead of just behind the elbow as you would with the probe. You would measure to the last rib, and that's how you would insert it into the esophagus. You would insert it this end here. And then generally this is the end that is sticking out of the patient's mouth. And then, however, the doctor wants you to use it, generally we would have it hanging off for like a basin underneath it to catch any bodily fluids that may come out of the tube. Because generally whenever you place one of these, there are going to be some bodily fluids that come back up through the tube. So you would place some sort of basin underneath it to collect those bodily fluids. Okay, so we're going to go ahead and place our ECG clips. I'm going to go ahead and place a conductive gel on the areas where we'll be placing the clips. Okay, so our machine does have 3 clips. Some of them will have 2, some of them will have 4. They are color coded. They also have labels on them. The white one is also always going to go on the right front arm. We're going to place that now. The black one's going to go on the left front arm. And our red one's going to go on the back left leg. So you can see where I have these placed. I have this one placed just behind the elbow on the front arms. The back one I have placed just on the skin around the inguinal area. And you can see it has started to read. The ECG clips do read the electrical impulses of the heart. It will track the heart rate for us as well as do the electrocardiogram for us. Okay, we're gonna go over how to properly choose the correct size for endotracheal tube for your patient. There is a weight chart based off of kilograms that you can go off of as far as what size to choose. But choosing the correct size endotracheal tube is also gonna come with experience. For Lacey, for our procedure today, I'm expecting her to be around a size 10. She is about 23 kilograms. On the chart, it says to choose an 11 and up, but her airway is just a little bit smaller. So I am going to choose around a size 10 endotracheal tube. You do want to have a range with you whenever you go to intubate. So you want to choose about a 0.5 millimeter size down and a 0.5 millimeter size up. So I also have a 9.5 here and a 10.5 as well. And then we are going to leak test all 3 of our tubes. So we have a 12 cc syringe, and we're going to go ahead and inflate each cuff. Okay, we have our cuffs inflated. We have our cuffs inflated. We're just gonna make sure that they're not leaking at all. This is important because if you have a leak, then your endotracheal tube may start to slip out of the patient's trachea. You could also risk aspiration if you have a cuff that's leaking. So we want to make sure that it's not leaking, which none of these cuffs appear to be leaking. So we're gonna go ahead and deflate them, and then we will grab a tie for our tube so we can make sure to secure our tubes in place. Okay, so for respiratory monitors, most clinics will have a capnograph. This one is not functional. It is broken. They do break very easily, so you do have to be gentle with them. But these are basically used to measure the expired CO2 for your patient. It is connected between the ET tube and the rebreathing tube that you're using. It goes in between those with a little plastic piece that connects the two. So these are used to help monitor respiration in your patient. It can tell you if the patient is in a good plane of anesthesia. So basically, if the EtCO2 has a low level, that means that your patient is hyperventilating, breathing really quickly. That means that they could be in pain, or their anesthesia level could be too light. If they have an EtCO2 level that is too high, they are in hypoventilation, so they're not breathing enough. They're not getting enough oxygen, and that CO2 is building up, which is making that EtCO2 level higher. The normal levels for EtCO2 are between 35 and 45 millimeters mercury for dogs and cats. So this is a really useful tool to have, so you can keep track of their respirations and know if they're either not ventilated well enough, or you're overventilating them. It's a good indicator for that. Okay, we do use a non-invasive blood pressure machine here. So we have a cuff that is hooked up to our anesthesia monitor. You do want to make sure that you're using the appropriately sized cuff for your patient. You want the width of your cuff to be about 40% of the circumference of the limb that you're placing the cuff on. The cuff will inflate and then deflate, and it will give you a diastolic and systolic reading of the blood pressure, which then you can see on our screen here. So right now her blood pressure is 123/45, and her mean arterial pressure is 71. Cuff placement is also important. You can place it on the hock back here. You can place it on the tail. You can place it on the front leg just here as well to get a proper reading. So for temperature, there are temperature probes that you can place in the rectum, which would stay there throughout the procedure, and it would read the temperature for you and report it on the screen. We use the rectal thermometers, which look like this. So you just place lubricant on the tip of the thermometer, and then you would insert it rectally and take the temperature manually that way. And then her temperature is at 98, so we are going to go ahead and place a blanket on her, and then maybe a fluid line warmer as well. This is Dr. Hooker. She's my preceptor, and she will be participating in the rest of my video. Okay, so we're gonna go ahead and place catheter on Lacey. I've already set up for it. We have our chlorhexidine scrub, our alcohol scrub. We have our appropriately sized catheter. We have our flush, and then we have our T-port. I am gonna go ahead and flush out our T-port. Alrighty, we're gonna go ahead and shave our spot for our catheter. I am using a 40 blade just to remove all of the hair. Really quick. I'm gonna go ahead and palpate for her vein. Okay, right there. All right, I'm gonna start with my chlorhexidine scrub. And then my alcohol. And we're gonna scrub 3 times with each solution. You're okay. All right, now to place our catheter, we're gonna make sure our bevel is up. We're gonna go at about a 30-degree angle. Once we get a flash, we're going to advance our catheter. I'm gonna occlude the blood flow. Okay, there we go. And now I'm gonna go ahead and start taping. We're first gonna do sticky side up. Fold that over to create a tab. Okay, with our second piece of tape, we've created a little divot. We're gonna go sticky side down. As such. Okay. We're gonna go ahead and place our T-port. Again, I'm just gonna occlude that blood flow. This one we're gonna do sticky side up, and then we're going to crisscross it like this. And then we're gonna go ahead and flush our catheter, make sure it's patent. Okay. And we have flow. So we are patent. Now I'm gonna take this line and tape it down. Okay. Go ahead and clamp this off. And we're gonna place our vet wrap. And now she has an IV catheter. Okay, this is Dane. We're going to be placing a medial saphenous catheter on him. So I already have set up, I have my chlorhexidine scrub, my alcohol rinse, my catheter, our port, flush, and then I have my pieces of tape already and my vet wrap. So I'm going to go ahead and shave where we're going to be placing the catheter, and I'm shaving with a 40 blade. scrub jacket or a lab coat or a smock or something so you don't get hair on your scrubs during this process. So I'm going to go ahead and scrub the area. I'm going to start with the chlorhexidine. We're going to do 3 chlorhexidine scrubs and then our alcohol rinse. Alright, now that this is scrubbed, we're going to go ahead and take our catheter. We're going to make sure our bevel's up. You have good angle. Okay. Bevel is up. We're gonna go at about a 30-degree angle. We're gonna puncture our vein. And then once you get a flash, you can advance your catheter. We're gonna hold off. Place our placeholder. There we go. And now we can go ahead and start taping. So we're gonna start with our first piece of tape. We're gonna do sticky side up. Okay, sticky side up. We're going to fold it over to create a little tab. You want to stay at the base of the catheter. You don't want to cover where you have to screw in your port. Next, we created a little tab in our tape right here. So we're just going to slide that sticky side down under our catheter. Alright, we'll go ahead and place our port. Again, we're going to hold off on the blood flow. Our next piece of tape, we're going to go sticky side up, and we're going to crisscross it as such. Flip it around. Keep that port in place. Go ahead and flush it. Make sure that it is patent. It is. I can feel it flushing through the vein. And then we're going to go ahead and take our vent wrap. Place that over the catheter site. And we still have our port exposed if we need to do any injections, but that is how we place a saphenous catheter. We are going to give a subcutaneous injection of Rimadyl. So we're going to tint the skin, and you're going to go right into that subcutaneous layer, and then you're going to aspirate to make sure you don't get any blood, and then go ahead and give your injection. Okay, we're going to be giving an intramuscular injection. We're going to be doing it on the rear thigh. The sciatic nerve does run along the thigh of the patient, so you do want to make sure that you're not going to hit that sciatic nerve. So we're going to place our thumb over where the sciatic nerve is running, which would be about right here. You're going to take your medication that you're giving, your syringe, you're going to go at a 45-degree angle, caudal to the sciatic nerve. You're going to go in the muscle. So we're going to go 45 degrees into the muscle. We're going to aspirate to make sure we don't get any blood, and then we're going to give our injection. We're going to be giving an IV injection. You can give IV injections. You can do the cephalic vein, you can do the saphenous vein. We're going to go ahead and do the cephalic vein. So we are going to occlude the vein up at the top of the leg here. We're just going to roll off and occlude. We're going to palpate for our vein, which is going to run right along the top of the leg here. I'm going to do a dab of alcohol. And now to give my injection, it's going to be similar to drawing blood from the cephalic vein. You're going to make sure your bevel is up. You're going to go in at a 30-degree angle. You're going to draw back, and once you get blood flow, you're going to stop occluding the vein, and then you're going to go ahead and give your injection. And then you want to hold off on the puncture site for 30 seconds. Okay, so we've pre-medicated Lacey with midazolam and hydromorphone about 20 minutes ago. We're going to go ahead and start with IV induction. First, I am going to measure from her thoracic inlet to her larynx. We're going to measure about halfway to see how far we need to place the tube. We're going to try not to touch the tube to her, just to keep it clean. Here. We're going to go ahead and place our tie on here so we know how far the tube needs to go in. Okay. We're going to go ahead and induce with alfaxalone. I'm going to flush first. And whenever you give an induction agent, you do want to titrate it to effect. So she has relaxed. We're going to check her jaw tone. Let me go ahead and flush this first. Okay, jaw tone is good. So we're going to go ahead and intubate. We're going to pull her tongue out. We're going to take our ET tube. The epiglottis, I'm going to tuck that down to expose her trachea, which we can see there. And then I'm going to go ahead and advance my tube into the trachea. And then we're going to go ahead and tie our tie in place. Tie this around her nose. It's short. Okay. And then we can go ahead and turn her lateral. We're going to turn the other way. All right. And we're going to go ahead and check our cuff inflation. So, 2. Do you want to give her a breath, honey? I'm going to go ahead and slightly inflate it, and then I'm going to listen for any air leaks. One more time. Okay, I'm not hearing any air leakage. We're going to listen to her lungs as well, just make sure we don't hear any crackles. Okay, everything sounds clear. So I would say our ET tube is placed correctly, and we're going to go ahead and continue with our procedure. Now that we have her properly intubated and induced, we are going to go ahead and lubricate her eyes. So we're just going to apply a strip of eye lubricant on each eye, just to make sure that her eyes stay lubricated throughout the procedure. Okay, we're gonna go ahead and express her bladder. So I'm just gonna palpate and feel for her bladder. There we go. It's not very big, but we did get some urine out. So we did get some urine expressed from her bladder. We have a 7-month-old male Jack Russell Terrier that we're going to be neutering today. So we're going to go ahead and prep him for surgery. We're going to shave where the incision's going to be and then scrub that area as well. We do want to wear a lab coat or a scrub jacket while doing this because you don't want to transfer any hair into the OR. So first we're going to start by shaving. You do want to shave with a 40 blade. And you want to shave large margins because you don't want any hair in the surgical site. Okay, and we'll try to be sure to get as much hair off of him as possible before we scrub. After we've shaved, we're going to open a sterile scrub pack. Okay, and we're going to be scrubbing. You do 3 scrubs with the chlorhexidine scrub solution, and then you'll do 3 scrubs with the alcohol rinse. Sometimes you may need to do more than that if you have a very dirty patient that has a lot of debris on their skin. We'll start with our chlorhexidine scrub. We're going to grab the gauze square by 3 corners. As such, so you'll have one corner still sticking out. We're going to take it and you're going to start where the incision site is, and you're basically going to work in like a bullseye motion. So we're going to start here and then scrub out. You want to be careful not to bring anything back into your sterile field, so you don't want to scrub out here and then go back into your sterile field because you'll just bring bacteria back into that sterile field. Same thing. We're going to scrub with our chlorhexidine scrub 3 times. We're going to start at our incision site and scrub outward. Do one more. Okay, and now we'll do our alcohol. One more alcohol. Scrub. Okay. And now we'll transfer him over to our OR, and then we'll do one more scrub once we get over there. And we'll go ahead and take off our scrub jacket as well so we don't transfer any hair into the OR. We're going to try to keep him sterile and not touch the sterile field as we transport him. Josh will go ahead and get him hooked back up to anesthesia, and I'll go ahead and put on his restraint ties. So we're going to add restraint ties to all 4 legs. We're going to attach it to the restraint tie holders on the table. And we'll go ahead and crisscross his front legs just to keep him stable and keep him from twisting and turning. We're going to do one more scrub as well, just to make sure everything is still sterile. So we're going to do one chlorhexidine scrub and then one alcohol scrub. Okay, and we'll go ahead and let the doctor know that he is ready for surgery. We do take a reading every 5 minutes of the heart rate, the blood pressure, the SpO2, respiration rate. We record the ISO percentage that we're at, the O2 flow rate that we're at, and then temperature, fluid rate, eye position, palpebral reflex, mucous membranes, and capillary refill time. And then for heart rate, as you can see over here, it is recorded on our screen. So she's at, right now she's at 55, which is a little low, but not too concerning for a dog of her size. Her blood pressure is 123/45, and her mean arterial pressure is 71. Our SpO2 is 99. And then our respiratory rate, we're going to count her breaths, how many breaths she takes in 15 seconds, and then multiply that by 4. So her respiration rate is at 20 right now. On ISO percentage, we have her at 2%. Her oxygen flow rate is at 1.5. And then for eye position, sorry. For eye position, she's central. And then for palpebral reflex, which would be if she is blinking or not, she is not blinking, so she does not have a palpebral reflex currently. Okay, and then we're going to check her mucous membranes. They are pink and moist, and her capillary refill time is less than 2 seconds. Again, we're going to take these readings about every 5 minutes. Right now she is stable. We are going to try to get her a little warmer, but besides that, she is stable for now. Okay, so we're going to talk about how to do CPR when you have a patient that is in cardiovascular arrest. So we have a little kitten here, stuffed kitten that we're going to use for demonstration. So whenever your patient goes into cardiovascular arrest, you immediately want to start chest compressions. That is the first thing that you need to do. So for chest compressions on a cat or small dog, you're going to use one hand, but you want to use your whole hand, not just your fingertips. You're going to place your hand directly over the heart, and we're going to give compressions, and we're going to compress that thoracic cavity by 30 to 50%. That's on small patients, large patients, you want to compress that thoracic cavity by 30 to 50%. If we had a large patient, you would use 2 hands, again, over the heart, same area, and then you would use 2 hands to compress their thoracic cavity. So you're going to give compressions at 100 to 120 beats per minute. And then after a 2-minute cycle, as more staff members come in, you're going to give compressions for a full 2 minutes, and then we're going to switch out. So as staff members are coming in to help with CPR, as one person is doing compressions, someone else is going to begin to intubate the patient. This is if they're not already hooked up to an anesthetic machine. So someone would come in and intubate the patient. They would intubate the patient while the patient's in lateral recumbency. And so after intubation, you need your ambu bag. Unless the patient is already hooked up to the anesthesia machine. In that case, you would use the rebreathing bag that is on the anesthesia machine. So there are a variety of ambu bags. They come in different sizes. It's ideal to have several different sizes depending on the size of your patient. Just like your reservoir bags, you want a smaller ambu bag for a smaller patient and a larger ambu bag for a larger patient. We only have one in our hospital. It is this one. They generally also come with an oxygen line that hooks up to your oxygen outlet for fresh oxygen. You can also just use it as is to just supply airflow to your patient and room oxygen. Obviously, that's not the most ideal thing to do. The most ideal thing probably would be to hook them up to the anesthesia machine so they have that pure oxygen flow, and you can give them breaths using the reservoir bag. But if you're using your ambu bag, again, you would intubate them. Once they're intubated, you would connect your ambu bag to your ET tube, and then we would begin giving breaths. And when you give breaths, you want to give one breath about every 6 seconds or 10 breaths per minute. And you don't want to, you're not going to squeeze like this or anything like that. You're going to give just one breath. Your breath should last about 1 second. You also have to, again, think about the size of your patient's lungs. So you don't want to overinflate their lungs or anything like that. So we would just give one breath for 1 second, wait 6 seconds, give another breath. So your ambu bag, just to go over it, this is your ambu bag, this is your reservoir bag. It does have an attachment to connect to oxygen. It also has an attachment up here to connect to a facial mask. So that is also another option for your ambu bag, depending on what type that you have. But again, for CPR, you do in combination your chest compressions. For small patient, we use one hand. So you'd be doing your chest compressions 100 to 120 beats per minute. And then another person would be giving your breaths every 6 seconds. Okay, so really quickly, just to go over if our patient were to be hooked up to the anesthesia machine already. So they're already intubated. We have our rebreathing system or non-rebreathing system hooked up to the ET tube. So for this patient, it's a small patient, less than 15 pounds, so they would be hooked up to our non-rebreathing system. If they were go to cardiovascular arrest and we were doing chest compressions, basically to give our patient a breath, the anesthesia machine is already hooked up to pure oxygen. So we would turn off the anesthetic gas and then just be delivering oxygen through the anesthesia machine. But to give a breath, we would basically open our port on our non-breathing system. You would give your breath, close it, wait 6 seconds, open it again, give your breath, close it, wait 6 seconds. And that's how you would give your breath with the non-breathing system. If we had a large patient and say they were hooked up to the red pediatric tube or to your blue tube, you would have your reservoir bag on here. Again, your rebreathing system would be hooked up to your ET tube. We would just be delivering oxygen. You would hold off on your pop-off valve. So we would hold off our pop-off valve. We would give a breath, wait 6 seconds, and then again, give a breath. Okay, so today we're scrubbing in for an 11-month-old Rottweiler mixed spay. Before you scrub in, you want to make sure that you have everything that you need set out. So we have our gown, our towel, our face mask, and our hairnet. And then we have our scrub brush. I'm going to go ahead and open my towel and my gown. So here, okay. And then we'll go ahead and set out our gloves as well. Okay, and then before scrubbing, we're gonna remove any jewelry, name tags, anything like that needs to come off and be set aside. We're gonna go ahead and put on our mask and our cap. Have any hair sticking out. Okay, and so first, we're just going to do a general cleansing of our hands just with soap and water. You do want to go all the way up to your elbows. Now we'll go ahead and open our scrub brush. Okay, so we'll take our scrub brush. So in your little pack you have the scrub brush, you also have a nail pick. So we're going to keep the scrub brush in one hand. We're going to take our nail pick and we're just going to make sure that our nails are cleaned thoroughly. We don't want any debris under our fingernails. Hands. Okay, and then after we've done that, we can throw the nail pick away. And at this point, you don't want to touch any of the space around you with your hands. You want to keep your hands from touching anything. So we're first just going to do 10 swipes across our fingernails with the side of the brush, the rough side. Okay, and now we're going to start with our fingers. So each area that you scrub, you're going to do 10 swipes. So we're going to do this 1, 2, 3, 4, 5, 6, 7, 10. The next side of our finger, 9, 10, and then we're just going to follow our fingers along.
Stress angry ear or real angry ear.
And then we'll do the back of our fingers. Flip our hand over. And then you'll come down to your palm. Back of your hand. And then we're going to work our way up to our elbow. So we'll do our wrist.
I can do it here. Let me touch. You let me touch it. I think you should get your mask because you let me touch.
And now we're going to leave this and we're going to come over to the next hand because we want this to sit because contact time is important. So we're going to do the same thing on this hand. Now that we have scrubbed with our scrub brush, we can go ahead and toss it in the trash. Still, don't touch anything. We're gonna go ahead and rinse. We're gonna start with this hand. So we're going to go under the water first with your fingertips, and you're gonna let the water run off of your elbow. You don't want the water coming back down because that's gonna bring microorganisms back down into your sterile area. So we're gonna go fingertips first. Alright, same thing on this side. Okay. Alright, and now we're gonna come over and we're going to grab our towel. You want to hold it away from you. You also want to hold your arms out in front of you. You don't want to come in contact with your scrubs because your scrubs are not sterile. So we're going to take one side like this. We're going to start at our hand and then we're going to work down. Then we're going to flip it to the other side. And we're going to dry this hand. Okay. And now we can take our gown, grab it from the top. Okay. And then you want to find your arm openings. Okay, and then we'll have someone come tie us in. Someone. You want to leave your hands inside of the sleeves until you have your gloves on. Thank you, Dr. Hooker. Okay, and now we're going to put on our gloves. So we're going to come over to our gloves and we're going to do the palm to palm technique. So you're going to grab your glove and it's going to go palm down. And it's going to match up with your thumb. The fingers are going to go towards your elbow. So we're going to take the opening of our glove and we're going to slide it on. Find your fingers. Okay, and then you can adjust your sleeve. We'll bring this down. Okay. And now that you have this on, you can take your other glove. And we're going to do the same thing. Okay, now that we're scrubbed in, you don't want to touch any surfaces that are not sterile. So you're going to just hold your hands together like this, and we'll go ahead and go into the surgery suite. Okay, so we'll go ahead and open our pack. And we have our towel clamps on top and our drape. We have our sterile indicating strip. we're first gonna open our drape. We want to be careful not to touch anything. Okay. And then we're going to take our scissors. Our sternum's right here. We're gonna come down about right here and make a cut in our drape. Okay, and then we're going to take our towel clamps. We're going to clamp our drape in place. Okay, so we're going to organize this first. Okay, so we're going to take our scalpel holder and our scalpel. We're going to go ahead and load our scalpel onto our scalpel holder. Okay, so we have our scalpel loaded onto our scalpel holder. We'll set that aside.
See what we get. And can you hand me the straight scissors? Thank you. So you still aimed very well, because next time try and
Okay.
cut that out a little bit so it's more not tinted up as much. Alright, hand me the scalpel please.
My hand is the handle first.
Thank you. And then can you also hand me a gauze? So usually I plan these based on age. So we're going to go one scalpel length back from the caudal umbilicus, which is over 6 months old. So we'll start raising this right here. About that big, a little bigger than right now. Hands like you. Can I get some Metzen Bomb scissors? And the thumb forceps. That's in Browns. Forceps. So actually the ones that will alligator claws. Thank you. Now you can have some of that.
Okay, our doctor is closing up. She no longer needs a sterile assistant, so we're going to go ahead and scrub out. So So the duties of a sterile technician are to maintain sterility, manage the instrument tray, pass instruments to the surgeon, and maintain hemostasis, like moistening tissue, stuff like that. So when passing instruments to your surgeon, there's specific ways you have to do that, which we will go over, what we did go over in our video earlier. But again, so if you have something such as hemostats or needle drivers, something like that that has your rings at the bottom, you do want to make sure that they're hinged, and you will pass with your rings down. So you will pass like this to the surgeon. So hinged, rings down, and pass like this. For a scalpel holder, with your scalpel attached, you would pass like this. You want the scalpel facing towards you and not the surgeon when you're passing it. So you would pass handle first, so they can then grab the handle and not injure themselves whenever reaching for the scalpel holder with the scalpel on it. If you were to break sterility during a procedure, like if you were to touch something contaminated or puncture a glove, the non-sterile assistant would go and grab another pair of gloves, and then they would open those gloves for you, and then they would take off your contaminated glove. So they would do that by pinching the glove and the sleeve of the gown, and they would pull them simultaneously, which would remove the glove, and it would pull your gown sleeve down over your hand, so your hand is still protected within the gown. And then you would re-glove the same way you put the glove on whenever we scrubbed in. So you would do the same thing, put that glove on the same way. If you were to break sterility, say you dropped an instrument, that instrument, if it's an instrument that we need, it can be flash sterilized. So it can be, we do have a flash sterilization on our autoclave, so it can be flash sterilized that way, but it is also a good idea to keep instruments sterilely packed, like singularly. So for example, we have singularly wrapped instruments that are sterile. So if you were to drop an instrument, we have backups that could then be opened by the non-sterile technician, which you could then sterilely grab from them. So they would just open the packaging, present it to you, and then you would just take the instrument. And to elaborate on flash sterilization, so that is generally only used whenever you drop an instrument in surgery. It again is a setting on our autoclave. So the autoclave would reach a temperature of 272 degrees. It takes about 10 minutes for it to reach pressure, and then it would begin the sterilization process, which would take 3 to 4 minutes. Whenever you do a flash sterilization, you have to be very careful because the instrument is going to be hot after it's been sterilized. So you have to be really careful taking it out of the autoclave. You have to be really careful passing it over to the sterile technician or the surgeon, because again, it can be very hot after flash sterilization. But that is a good technique if you have an instrument that you drop in surgery and you need that instrument. Flash sterilization is a good procedure that you can do. So today we're doing a feral cat spay. She's an approximately 1-year-old domestic short hair, and we're going to go ahead and spay her today.
My name is Dr. Alexis Hooker. I am Megan Birdwell's preceptor. I am recording this just to say that she has participated in a feline neuter.
Okay, so we're gonna do a post-surgical cleanup of our surgery suite. So any towels, cotton wraps, such as this, anything like this is gonna go in the laundry. So we're gonna go ahead and set this in a pile to the side so we can take it to the laundry after we're done. Okay, and then for any disposable sharps, they're gonna go in this sharps container. So we'll place them in here, and then we do have a company that comes and picks up our biohazard waste and our sharps after we have filled up these sharp containers. They'll come and pick it up and dispose of it for us. We just need to check for our sharps. So we do have our scalpel. We're going to go ahead and remove that from the scalpel holder. And then we're going to place that in our sharps container. And then you also want to get rid of your needle because it is sharp as well. So we'll go ahead and put that in our sharps container. And then any tissue that was taken during surgery, basically we're going to remove the clamps. And we're going to place this in the trash, and we're going to double bag it, and then we're going to dispose of it in the trash. Okay, so now all of our instruments are going to go in the sink so they can start pre-soaking. So we're going to take all of our instruments over to the sink. We're going to dispose of this leftover fluid as well. Okay, so all of our monitoring tools, such as our pulse ox and our ECG clips, they're all going to get wiped down with alcohol. So these are pre-soaked alcohol gauze squares. So we're going to wipe everything down with isopropyl alcohol. Make sure we get any debris, any saliva, blood, anything like that needs to be cleaned off of these. And then we are going to just gently wrap up our cords and neatly place them away. Our blood pressure cuffs have a drawer that we place them in, that we store them in when they're not in use. So all of these little things get placed in storage drawers. Okay, we're also going to dispose of the surgery trash. So like I said, we're going to go ahead and double bag it. So we're going to put it in a larger trash bag, and then that will be disposed of at the end of the day. Now that we wiped everything down, all of our monitoring tools and everything have been wiped down with alcohol, we're going to go ahead and use a disinfectant. So the disinfectant that we use in our clinic is Kennel Care. So we do have a bottle that stays in surgery that's already diluted. So we have our diluted Kennel Care. We're going to go ahead and spray down the surgery table, the Mayo table, and then our other table over here that holds our instruments. We're going to spray everything down. We're going to let it sit for 10 minutes according to the manufacturer instructions. It's going to sit for 10 minutes, and then we're going to come back and wipe it up. Okay, so now that the Kennel Care's been sitting for 10 minutes, we're going to go ahead and wipe it clean. Okay, now that our surgery room is clean, we do have another surgery to do, so we're going to go ahead and set up for that. At the end of the day, we'll do a terminal cleaning, so we'll get disinfected again, we'll sweep, and then we will mop with disinfectant as well. Okay, so we're going to go ahead and clean our surgery instruments. So you do need a surgical instrument cleaner, which we have the Miltex surgical instrument cleaner here. So we're going to take some distilled water, and you're going to pour some in our basin here. You want to pour enough to where it's going to cover your instruments. And then we're going to mix in some of our instrument cleaner. Okay, and then whenever you're, we're gonna pre-soak our instruments first before we clean them. We're gonna soak them for at least 20 to 30 minutes. You do wanna make sure they're all unhinged or unblocked. Each one, you don't want it to be closed like that because you're not gonna be able to get in all of the crevices and make sure all of this is clean. We're gonna make sure they're all unlocked. We're gonna
Oh my god. It really does hurt. You gotta be careful there.
Okay, and so now we're just gonna let these soak, and then we'll come back and we will manually clean them. Okay, so we're gonna go ahead and manually clean our instruments. We're gonna take a soft bristle toothbrush, put a little bit of cleaner on it. And then we're gonna take our instrument. Again, you wanna make sure it's not ratcheted. And we're going to clean all of the crevices with our toothbrush. We're gonna fill this basin with some distilled water. Okay, and this one's just gonna have distilled water. We're going to place our instruments that we have cleaned in the distilled water to rinse them off. For these, you do want to make sure that you get in all of the teeth, and you want to clean between all of those. Make sure there's no blood or tissue in between those. If we ever have anything stuck, any tissue or anything like that stuck between the teeth of some of our instruments, we'll take a little wire pick and we'll just pick out any debris in between the teeth, because you want to make sure that you don't have any debris left on your instruments at all. You want them to be as clean as possible, so we will go ahead and pick out any debris that needs to be picked out as well. After we have rinsed our instruments, we're going to lay them out on a towel for them to air dry.
I'm not gonna print.
Okay, after our instruments are completely dry, we are going to spray them with this surgical lubricant. So just to maintain their life, keep them from rusting and stuff like that. So we'll wait for them to completely dry, and then we'll go ahead and spray them with this. Okay, now that we are dry, we're gonna go ahead and spray down all of the hinges with our lubricant. Okay, and we are just gonna go through and make sure that all of our instruments are working properly. We're just gonna go ahead and move the joints, make sure nothing is touching and everything is working as it should be. Okay, so we're gonna go ahead and wrap a surgical pack that's already been cleaned and lubricated. So we have our instruments that we'll be wrapping here. We have two cotton wraps. We have a larger one and then a smaller one. Yeah, of course. The larger one is going to be for our outer portion of our wrap, and then the smaller one is going to be the inner portion of our wrap. We have a drape that is folded accordion style. We pre-fold them. So It is folded accordion style. I'll go ahead and unwrap it and show you. So it is just folded accordion style this way. And then we folded accordion style this way as well. And then you have your drape. And then we have a field towel as well. We have some gauze. We have masking tape and then sterilization indicator tape. And then we also have sterilization indicator strips as well. So before we wrap anything, these have been already put through the laundry. These wraps and towel have, but we're gonna go ahead and lint roll them first because we don't want any loose hairs on any of our surgery packs. So we're gonna go ahead and lint roll them first. Okay, now we're gonna set our smaller wrap on top of our larger wrap. Okay, we're gonna turn it so it looks like a diamond. You're gonna take your field towel and we're first going to fold it in half this way, long ways, and then you're going to accordion this as well. So we're gonna go ahead and start here. And we're gonna accordion fold our field towel. We're gonna place that in the middle. So then next we're gonna go ahead and grab our instruments. So most of our packs have a spay hook included. So you're going to take your forceps, your scissors, your needle drivers, all of these instruments are gonna go on our spay hook. So we're gonna organize them first. So they're gonna be organized, basically our scissors are gonna go on first, because our doctors are gonna need the scissors first to cut the drape. And then we'll put our needle drivers on second. And we'll go ahead and run them through our spay hook. And we're gonna set that on top like that. And then we'll take our hemostats. We have curved hemostats and straight hemostats. We're going to start with our curved hemostats. We're basically going to arrange them by size. So we have the small curved hemostats and then the larger curved hemostats. And then we'll go ahead and arrange our straight hemostats. And we're gonna set these on the spay hook as well. Alright, and the reason that we place them on the spay hook is just to keep everything in place and keep it organized. And you can spread them out.
Drop off checkout for Emma. Drop off checkout for Emma.
You can spread them out on the spay hook as well. Emma has a fecal cup, but she just had a fecal done. It just comes with the panel that she's getting, so she doesn't have to bring it back if she doesn't want to.
Okay.
And then we're going to take our scalpel holder and we're going to place it on the side over here, as well as our thumb forceps and our Addison forceps. We're just going to place those on the side as well, as such. And then now we're going to go ahead and place our sterilization indicating strip on top of our instruments. Okay, so we have our sterilization strip. It looks like this. And again, we're just gonna place that on top of our instruments. And then we're gonna take our gauze. And we're gonna place 2 stacks of 20 on top of our instruments. All right, and the reason that we count out our gauze is because you don't want any gauze misplaced or left behind somewhere in surgery. So we count out how many gauze that are in our pack, so we know how many should be left over after the surgery is finished. So we have our gauze. We're then gonna place our drape again. Our drape is folded accordion style. We're gonna place our drape on top of our gauze. And then we're gonna take our towel clamps, we're gonna place them on top of our drape, and this is because our doctors are going to need the towel clamps immediately whenever they place the drape. So our towel clamps are going to go on top of our drape. Okay, now that's good. We're going to go ahead and start folding our wrap. So you're going to take one corner, you're going to fold it in, and then you're going to fold it back to make a little tab. And then we're gonna do the sides the same. So we're gonna fold it in and we're gonna try to make it tight. Make a little tab, take the other side, fold it in, little tab. And then for this one, turn it around. We're gonna take this, fold it in, and we created a little slot here. We're going to tuck this in that slot. Like that. And you're gonna leave this little tab out. This is what the doctor is going to pull to open our pack. So we're gonna do the same thing with the outside wrap. We're going to fold it in. Make a little tab. Take the side, fold it in, make a little tab. Take this side, fold it in, make a little tab. And with the outer layer, I am making it a little bit tighter, just because you want everything nice and packed in. And then again, this one, we're gonna fold it in. We're gonna place it in this little slot. And it should look like this whenever you are finished. And so then after we've done that, we're gonna take our masking tape and you're gonna place a strip along the top, over the side, and connect it to the bottom, like that. And then we're gonna take our indicating tape, sterilization indicating tape. You're gonna cut off a strip about like this. And we're gonna place that on the outside layer as well. And now we're gonna take a Sharpie and we're going to write what this pack is. So this is a what we call a mini pack. So we're gonna put mini pack on here. We're gonna put today's date. And we're gonna put our initials so they know who wrapped it. And now this is ready to be put into the autoclave for sterilization. Okay, we're gonna be wrapping a surgery gown. So we will need a large cotton wrap. It has been already through the laundry, so we're gonna go ahead and lint roll it to make sure we don't have any loose hairs on it that will transfer to our gown. Okay, now that it is lint rolled, basically gonna go ahead and lay it down on the table. You want the inside of the gown to be facing the table. I'm just gonna spread it out. You're gonna take your sleeves and we're gonna just lay them flat like that on both sides. And then we're gonna take the outside edges, we're gonna fold them to the middle. Make sure everything is nice and even. Okay, and then we're going to grab it in the middle and you're going to fold it in half like that. And then we're going to take this outer edge and we're going to fold it in half again. And now we're going to accordion fold it. So we're going to start at the bottom. We're going to fold it in, fold it under, over, under, over, and under. And then you want your ties to lay on top, so it's easy for the doctor to grab or the sterile assistant to grab. You also want to note the size of the gown. This one is a extra large. We're gonna set that aside. We're gonna take our wrap, open it up, make it in a diamond. We're going to set our gown in the middle. And then you're gonna take your sterilization indicator strips, which look like this. We're gonna place that on top. And now we're going to start to fold our wrap. So you're gonna take one corner and you're going to fold it in. You're gonna take the tab and you're just gonna make a little tab like that. And then we're gonna take the side, fold that in. You're also gonna make a tab with that as well. As such, we're gonna take the other corner, fold that in, make a little tab like that, and then you're gonna take your last corner, you're gonna fold it in, and we made a little slot here. We're going to tuck it in that slot and leave this corner sticking out. So the doctor can, or the sterile assistant can pull this tab to open up the wrap to get the gown. We're then gonna take our masking tape and you're gonna place it on top, across the side, and on the bottom, like that. And then we have sterilization indicating tape. You're gonna take this strip of this tape and you're gonna place this on top as well, like that. And then we're gonna take a Sharpie and you're gonna write on the masking tape, you're gonna write, it's an extra large gown. We're gonna write today's date and our initials. And so it will look like this. And then it's ready to be sterilized in the autoclave. Okay, so here we have our autoclave. This basically sterilizes our packs using distilled water and pressure. So if you open it up here, you can see here, this is where we place the distilled water. We pour it in this little port here. As it fills up, this indicator right here will tell you how much to fill it. So there is, go a little closer, a red indicator and a green indicator. You obviously want it in the green before you start it. So basically, we fill it up with distilled water. The autoclave electrically heats the distilled water, turning it into steam. As it steams, it forces air out through a port in the top, so air will be forced out. Once the steam pressure builds, it will reach optimal temperature for sterilization, and then it will go ahead and begin the sterilization process. After it has finished, the steam will go ahead and condense back into water, and then it will go into an automatic drying phase. It will crack the door open, and it will begin drying just so there's no condensation left on our surgery packs. So as far as temperature, it will reach the temperature anywhere between 250 and 270 degrees Fahrenheit. It will also reach 15 to 27 PSI. And then for a cycle, we have preset cycles on our autoclave. Depending on which one you pick, they run between 15 and 30 minutes. That includes reaching pressure, sterilization, and then drying time as well. So to load our autoclave with our packs, we have these little trays in here that hold our packs. If you have smaller things to sterilize, you can add multiple trays and then have several instruments that you can sterilize. We have larger packs today that we wrapped earlier. So we're just going to place one tray in here, and we're going to place them side by side. We want a little bit of space between them, which we have. We don't want to set anything directly on top of each other or really close together, because that's going to prevent proper sterilization. It's going to prevent sterilization all the way through the pack. So you want to make sure everything is pretty much spaced out in your autoclave. We'll then go ahead and shut the door and make sure it clicks shut. And then you'll select whatever you're going to be sterilizing. So if we flip on here, we have different presets. We are sterilizing a pack. So we're going to click packs. It's already preset to 250 degrees for 30 minutes. So then we're just going to press start. Okay, so we're going to show how to maintain our autoclave. So we do have Speed Clean. It is made by the same brand as our autoclave. So we just take a little bit of this and we place it on a gauze square. And then we also place some distilled water on there as well. So we'll mix the Speed Clean with some distilled water, and then we wipe the complete outside of the autoclave. And then we also will wipe down the inside gasket. And that's how we maintain it daily. To maintain it weekly, we will detach this drain tube here, and then we will pour out the distilled water from the reservoir basin. We'll completely empty it, and then we will refill it with clean distilled water. We'll also take out all of the trays. So all of these trays here, we will take these out, and then we wash them with soap and water. And then for the inside of the autoclave, we again will wipe it down with the Speed Clean and distilled water mixture. So we'll just give it a good wipe down. And that's how we would maintain it weekly. For monthly maintenance, we would again drain the distilled water chamber and fill it with clean distilled water. And then we would place a small amount of the Speed Clean at the bottom of the chamber. And then we would close it and we would select the pouches cycle, and we would run the pouches cycle to automatically clean the autoclave. Once it reached the drying phase, we would stop it, and then we would go ahead and open it. We would again drain the distilled water chamber and refill it with clean distilled water. After we did that, we would close it and we would run the unwrapped cycle to rinse the autoclave. And then after that, it would be ready to go. And that's how we do our monthly maintenance. So to ensure pack sterility, the sterilization indicator tape that we placed earlier, after it's gone through the autoclave, it will have these little black strips that pop up on it, indicating that it has been sterilized. Also, once we open it, either the doctor opens it or the sterile assistant opens it, that indicating strip that we placed on the inside will also turn black as well, indicating that it was sterilized all the way through. Okay, this is Rose. We're going to be doing a suture removal on her. So for suture removals, whenever they come in, you first just want to assess either the wound or the incision. Wherever the suture is replaced, you want to make sure that the area is completely closed, so there's no opening of the skin, anything like that. You also want to make sure that it doesn't look infected, so we don't have any oozing, any pus, nothing like that. Hers looks pretty good. It looks pretty clean. She does have two simple interrupted sutures, so we're going to remove those individually with our suture scissors, which are these right here. You're going to use this hooked side of your suture scissors to hook the under part of the suture. So we're going to go underneath the suture. Okay, and then once you're under the suture, you're going to cut it. All right, and then we will pull that suture out as such. Okay, and then she has one more. So again, we're going to hook underneath that suture, cut it, and then we're going to pull that suture out. Okay, and she just had the two. Again, it looks pretty good. So we're just going to take her back up to her owner.